Good morning, everyone, or afternoon, depending on where you are in the world. Thank you for joining us at the AIM Center for our quarterly webinar on relapse prevention planning in collaborative care. We thank you for joining us, and I am Monica Harrison with the AIM Center. I'm joined today by my AIM Center colleagues, Sarah Barker and Christy Malmstrom are here with me. And in giving you information about the AIM Center helps support organizations implementing the collaborative care model through coaching and clinical training. Since 2017, we have also developed technical expertise in billing and financing collaborative care and have gained national recognition in this arena. The purpose of the AIM Center is to inspire providers, researchers, and decision makers to transform healthcare and improve patient outcomes. We accomplish this by translating and researching evidence-based approaches to behavioral health integration. This call is being recorded, and we'll be sending out a link to the recording and the slide deck to everyone who has registered. This webinar format accommodates our large audience today, and you'll see on your Zoom screen that there is a Q&A function. So we're asking you to use that instead of chat. You can enter your questions for the presenters at any time, but we'll only answer the questions after all the presentations are concluded. Today, we'd like you to focus questions on the experiences of these expert presenters that we have today. And if you have general questions about implementation or financing collaborative care, please bring those to our implementation or finance office hours. You can also check out our FAQs on our website. And so Christy is putting the link to both of those office hours in the chat now for those of you who want to or need to attend those. At the end of the session, participants should be able to describe the rationale for relapse prevention planning. Sometimes we call that RPP for short, in integrated care. Discuss the key components of an effective relapse prevention plan. Describe the optimal timing of relapse prevention planning in relation to ending an episode of care, and also generate ideas from other collaborative care programs on how to effectively put the relapse prevention plan into practice. So our presenters for today are Anna Hink, who's here with us at the AIM Center. We also have Ashley Shattuck with Hartford Healthcare and Tatiana Popoff with Multicare Behavioral Health Network. So I'm going to turn it over to Anna to kind of get us started in setting some foundation.
All right, thank you, Monica. Yeah, so I'm just going to talk briefly about relapse prevention planning and sort of some of the research and how it fits into collaborative care. And we'll talk briefly as well about considerations with other populations such as pediatrics. Next slide, please. So as you can see, a relapse prevention plan is a practice tool personalized for each patient to use to assess the impact and the occurrence of symptoms, while also being aware of risk factors, coping skills, resources available to them, and healthy behaviors that they can tap in to assist with their ongoing wellness. Relapse prevention theory is rooted in the developments of cognitive behavioral therapy. It was developed in the 1970s and 80s and initially developed for alcohol and drug addiction and sort of really focused on that sort of thought of why individuals are relapsing after treatment. And so in that theory, they sort of thought about kind of how addiction recovery requires long-term behavioral change and coping strategies. And that's then evolved into an adaptation. And as you can see here with collaborative care, we've adapted relapse prevention planning to fit into our populations that we serve as well. Next slide, please. So many of you already know these statistics, but they serve as a helpful framework underscoring the rationale for relapse prevention planning when considering adult populations especially. We know that the risk of relapse increases with each episode of depression and that each relapse results in greater severity of symptoms and greater difficulty responding to treatment. So the clinical goals with relapse prevention planning are to really decrease the relapse and to promote earlier intervention when the relapse does occur. But there's also programmatic goals really associated with thinking about the turnover of the caseload and making sure we're identifying when an episode of care does happen. Next slide, please. So there's several components or several elements really involved in relapse prevention plans. And here we've sort of listed most of what those will include. So these are things like proactive symptom monitoring that will continue beyond the acute phase of treatment and really help the patient think about monitoring their symptoms even after they end an episode of care. A relapse prevention plan will also help patients recognize their personal warning signs related to their mood concerns. It will help them really identify and distinguish the treatments that have been effective for their improvement and help patients to identify things that have helped them improve and that would be good to continue after the end of the episode of care. It also creates a really concrete, specific plan personalized to that patient that helps them think about what to do if their symptoms start to return. And so ideally, this plan is completed before the end of acute treatment. And that's something we'll talk about in just a few minutes of sort of really when to introduce this concept. And it's something that's completed in collaboration between the behavioral health care manager and the patient. And it's something that the patient will really own and have a good sense of ownership of after they end their episode of care as well. Next slide, please. So, one of the purposes of relapse prevention is to really empower the patient, and it can be very empowering to make sure the patient has access to the knowledge and education around the prevalence of relapse with depression and their symptoms, and especially empowering for patients who feel like to help them feel like they have a really solid set of tools that they can use to help manage and monitor their own symptoms. Ideally, relapse prevention planning will prevent the reoccurrence of symptoms, but it should also help a patient recognize when they need to ask for help. It will help the patient identify what worked and identify strategies for continuing to do those things, and then help them again to recognize their personal warning signs related to their mood concern and develop sort of a clear plan again if those symptoms return. So we're going to show you here just an example of what a relapse prevention plan template could look like. This is what we use here at the AIM Center. And many organizations we know will use this plan, or they will use a plan that's maybe already established by the organization, or something that might be established in their EHR, or they might just take this and then adapt it, to whatever is going to fit what best for their patient population. Some behavioral health care managers will create a smart phrase that outlines sort of the components of a relapse prevention plan that then they can really tailor it to each patient. So you can really be sort of nimble and flexible with how you use this. Um, this relapse prevention plan that we're looking at here has elements such as really, number one, getting the most out of your plan. So thinking about how can the patient incorporate accountability into their plan? How can they make sure they're setting themselves up for success? Where do they store the plan? Who do they use to help them support with the plan? And also thinking about sort of how often do they want to potentially revise this plan and reassess themselves for symptoms after they've ended care. As we mentioned before, this plan also includes helping patients to identify a list of personal warning signs if they're noticing their symptoms are coming back. It helps them identify any medications that they want to continue to use after their episode of care. And then again, it just helps them sort of list out things that they know are effective for themselves. So either treatment, it could be like problem-solving treatment, or just even healthy behaviors that they know they want to continue to use to stay well. And then lastly, it helps them sort of, here you can see a concrete plan for what to do if those symptoms return. Who should they contact? What happens next and things like that. So it's pretty specific and detailed there. Uh, Thank you. So in terms of variations, really feel free to name this plan whatever feels right for your population and your organization. Here you can see a variety of titles that we see different organizations use, such as a wellness plan or a maintenance plan. Um, you can be pretty nimble with this as well. And then when you're thinking about other populations that you're working with, you also want to make sure we're sort of catering this plan and the name of the plan to make sure it feels authentic to those populations. And I'll talk specifically around pediatrics in just a moment. Next slide. Great. So thinking about timing, so when do you want to introduce this plan? Typically, we think earlier is best, and partly because we know that when patients tend to do better. It's not uncommon for them to then disappear or potentially cancel appointments once they start feeling better. So we want to think about earlier planning can really decrease those missed opportunities to work on this plan together. It also just creates this transparency in how treatment can go, making sure they understand the different phases of treatment and that this will be relapse prevention planning will ideally be part of their process. So it kind of gives them a heads up of what's going on. And just thinking about just because you introduce relapse prevention planning or the idea of it early on doesn't mean that you move them from active phase to maintenance phase, for example. You can keep them in their active phase of care, but we just want to introduce the concept and make sure that they are getting used to that. And you can start working on that plan pretty early and then revise it over time. Next slide, please. So here are some guidelines to consider when deciding if it's an appropriate time to introduce a relapse prevention plan and when to initiate that process. Um, these are guidelines. There may be additional factors that you want to consider, such as like the number of visits or the number of weeks in treatment. What we really want to make sure we're considering, though, is their clinical improvement from their behavioral health measures and any observations that you're gathering from them as well. Okay, next slide, please. So some considerations when thinking about doing relapse prevention planning in pediatrics, we're thinking about using those same common elements in a relapse prevention plan for pediatrics. So similar template like you saw we introduced just a moment ago. But it's important to also think about maybe other organizations that might be involved in that patient's care. So maybe there's school supports also involved in that child's life that might fit into that relapse prevention plan. And you also really want to think about if there is a supportive adult in that patient's life, how can we involve them in the development and or the involvement of the relapse prevention plan over time so that we're collaborating together. And so that supportive adult can also help that patient have accountability to the plan, think about where they're going to store the plan, how they're going to use it to make sure it feels like a really effective tool. Um, Similarly, in pediatrics, we want to think about, similar timing of when you're going to introduce the plan. We're looking at early on introducing the concept, and then once you're seeing sustained improvement with their behavioral health measures, you're noting your clinical observation, the patient's giving you feedback, or you're getting collateral information from that supportive adult in the patient's life. That's when we want to think about really starting that plan. So similar to adult populations as well. And then when we're thinking about the title and the name, sort of how we organize the template, we just want to think about what's relatable to your patient population. So you may want to shift the name from relapse prevention planning to something that maybe is more fitting for your patient population. So in pediatrics, I've often heard a wellness plan or a stay well plan. And you want to think about how can we make that template sort of visually appealing to pediatrics. I've heard of people sort of shifting the template, adding color to it, adding little bubbles or drawings. You can be really creative just to make sure it's appealing and sort of visually attractive to the patients that you're working with, so it can resonate and stand out for them as a useful tool. All right, thank you. So Chrissy, that's the end for me. Thank you.
So hi everyone, my name is Ashley Shattuck. I'm an LCSW with Hartford Healthcare. I'm going to tell you a little bit about our organization and our integrated care programs. Next slide. So Hartford Healthcare is in Connecticut. It is a small state, but we do have quite a comprehensive network of support, including 500 locations spread out throughout our state. We have approximately 44,000 employees. For us in primary care, we have 72 primary care offices, and we are grateful to have 7 nationally recognized institutes, including our behavioral health network. You can see below, it's quite comprehensive as well. We have 330 inpatient beds and 164 addiction rehab beds and 35 ambulatory settings, which comes in handy when we're referring out for a longer term treatment from primary care behavioral health in the collaborative care model. And I'm proud to say we have close partnership with them. We also established a Center for Health Equity in 2023. Yay! Finally, long time coming, but I'll talk a little bit more about equity in a couple slides when it comes to COCM. So, a little bit about integrated care, what we do. So I'm the clinical program manager of both the primary care behavioral health and the collaborative care model programs. So you can see here, our PCBH covers 38 of those 72 primary care offices. We are co-located versus fully integrated where you're doing warm handoffs all day long. We do cover 7 endocrinology offices because a lot of us on this call, if not all of us, know that one of the biggest comorbidities with medical and mental health is diabetes and depression. So our collaborative care program, we cover 8 practices out of those 72. We actually have a new expansion strategy to make sure we're offering to 11 additional offices. And we have both models in 6 primary care offices. And I can tell you from experience, the BHCs and the BHCMs love that because they get to partner with each other regularly. And that'll tie into our graduation plan, the language we use when we go to the next slide. Okay, so as Anna said, we really like to set folks up for success. The way we do it in our medical record, which is Epic, we utilize Epic for Harvard Healthcare. Once our team, our consulting psychiatrists, the behavioral health care manager, and certainly the patient's, subjective report agree that really graduation is what we call it, is approaching. We have found that patients really like that language and graduate towards it because they feel proud of themselves. And so once we identify, of course, through systematic caseload review, we do inform our patient that, yep, all right, the time is coming. And when we're providing those psychiatric recommendations, and we do introduce the relapse prevention plan. So when it's actually completed with a patient is typically during the last follow-up with the BHCM. Now, if we are aware that the patient sometimes ghosts us on different months, we might start planning it sooner. So we really like to know and get a good sense of what's going to work for every individual patient. That's usually the standard. And then, of course, we're going to inform the primary care provider, and we do that by routing the final psychiatrist note to inform them that their patient is graduating and thank them for the referral and let them know specifically they can re-refer, or if the patient really needs to continue with specialty management. So some pro tips you can see from the picture on the screen, we have luckily a sticky note feature in Epic where only the BHCMs can see it. And we add in very personalized details throughout the episode of care to make sure that we are staying on top of what's important to them and can include that in their RPP. And as I mentioned before, we do have the blended model in 6 of those primary care offices. And so we will include the BHC in that graduation plan and make sure that they're on board as well. Okay. And for everyone's just awareness, we do have for our BHCMs, we have both bachelor's prepared and licensed, which is really exciting. And so graduation time, like I said, our patients really gravitate towards that language we've found. And, as Anna said, you can really tailor smart phrases to what is going to be eye-catching and encouraging. So you can see right here, dear so-and-so, we are thrilled to share your COCM graduation plan. Our team is incredibly proud of you and all the work you put in. And we give them permission. If you wish to reconnect with our program, just reach out to your primary care provider. And we wish you the best. And so our smart phrase is as simple as .cocm graduation. Okay, next slide. Okay, so this is what our template looks like that we turned into a smart phrase. You can see there are some standard elements from the AIM Center, and we do have some opportunities to improve it this year for 2025. So of course, maintenance medications. We like to give the directed call your primary care provider with any medication questions. Certainly they can reach back up to us and we would send a, encounter to the primary care provider to encourage them, to address the patient's needs. We like to include other treatments because a lot of our patients could be doing physical therapy, getting massages once a month, or acupuncture. We've had some patients do when they're doing a cross taper. Really try to make sure we're understanding the whole picture of what's going on for them and what's helpful. and certainly signs of increasing symptoms. We do review with them, that initial PHQ-9 and GAD-7 they came to us with, though it doesn't say here, but we say, hey, these were the symptoms that were really challenging when you first came to us. Would you consider those like your warning signs, right? And so we'll have a discussion about, well, no, the sleep actually, that was because I had a newborn, so that's evened out. But really, the anhedonia, me not wanting to go to the gym, that's the one. And certainly empowerment, right? Strategies that they use to prevent and manage symptoms, which we've learned along the way with working from them. So it's nice for us to be able to have that conversation and highlight, their successes for them in case they forget. That's why that sticky note comes in handy sometimes, because we can't remember everything and our patients can't remember everything either. So it's nice for us to have each other's backs. And certainly if symptoms return, we give specific directives. Are you trying your strategies? Are you taking your meds correctly? That's really important. Who are you seeing for counseling, PCP, social support, their best friend, their pastor, can they reach out to them? And definitely want to make sure they have information if they are experiencing a mental health crisis. For us, we do include, intimate partner violence as well. And we always like to make sure we include their next primary care appointment. You can go to the next slide. Okay. So utilizing MyChart. We have had a lot of success with MyChart when it comes to distributing the graduation plan. You can see here, we certainly title it, big congratulations, relapse prevention plan. It's right there with them. We don't include it as an attachment because some people might miss that. So it's right there in front of them. We have seen that before because we attach our COC and we have a welcome letter. And we ask patients, oh, did you read the welcome letter? Oh, I didn't know there was attachment. Okay. So that's been helpful for us. And in terms of how we connect the dots to the primary care provider, or maybe that BHC, we will route this MyChart message with the graduation plan to them internally. So they'll know it's completed, they'll see it. And I'll talk more about opportunities we have for making sure the whole care team has access to it. If we go to the next slide. Okay, so like I said, we established a Center for Health Equity in 2023, but that doesn't mean we weren't thinking about equitable options before then. So what we've learned, so our COCM program has been around for about 4.5, 5 years. A lot of our patients do prefer to receive that relapse prevention plan via MyChart than a hard copy. We'll certainly offer it to them because we know they don't check their MyChart as often as we would like them to, because we can see if they've read it or not. This does and has equated to easier access for re-referrals. We have patients reach back out to that MyChart message quite frequently to say like, hey, these symptoms are returned, or hey, I think I need an adjustment. And that allows the BHCM to say, did you try XYZ on your relapse prevention plan? Okay, you did. Let's reach out to your primary care provider and get a new referral. So that's easy for them. And of course, if there is no access to MyChart, people have choices and preferences. That's okay. We absolutely will mail it to their preferred address. And document that we did that within the final follow-up note. So the primary care provider and any of their specialties working with the patient are aware that it has been distributed. And we always offer to have that RPP translated into their language of preference. I think that's really important. We have a great language services department who really responds quickly to us. As an example, I asked them on Friday, to translate a COCM welcome letter into Korean for us and some smart phrases, and it was back to me 9 a.m. this morning. So, and we did have yesterday off, so I think that's a really quick turnaround. So we'd like to leverage them when we can. So some opportunities that we've noticed is, okay, so we're routing this MyChart message to the primary care provider. We're letting them know through that Epic consult note from the psychiatrist that graduation's here. But I think that it would be helpful if we uploaded that physical document into their media, what we call media clinical tab, where they have like after visit summaries, things like that. So the care team can look. And we do want to incorporate the self-monitoring for the PHQ-9 and GAD-7 screens. That's something we haven't done before in our relapse prevention plans, and that is going to be something we're going to do this year. And we also, so Hartford Healthcare has access to what's called the Hello World platform for texting. So this allows healthcare organizations to send notifications and reminders for patients to their phone if they don't have access to MyChart, and if they don't have access to the internet, they can still receive it. So I think that's really important for us to start utilizing in COCM, especially for folks who may not have access to the internet or just prefer to receive it in a text message. So that's something that we really want to be able to champion this year for our patients. It's nice to be able to work for this organization that really feels strongly about new innovative technologies, and we're certainly going to take advantage of that in integrated care when we can. Right. I think that's my last slide.
Awesome. Well, thank you. My name is Tatiana Popov. I'm an LICSW and I'm from Multi-Care Behavioral Health, and we're based out of Washington State. Next slide, please. So what does our model look like? And you can kind of go through that, Monica, and add it in. So we are an integrated model for primary care for pediatrics and specialty care, and we're providing visits both in person and virtual. We do 16 visits max in our episode of care. In our family practice settings, we do 60-minute assessments and 30-minute follow-ups. Pediatrics are 80-minute assessments and 40-minute follow-ups. And all of our clinicians, where we call the IMHTs for the behavioral health care managers, are working in behavioral health, but they are full-time employed in the primary care clinic. We are fully accessible for warm handoffs, curbside consults, more immediate appointments. We do no more than 3 back-to-back scheduled visits. That is, if there is a crisis or a need to connect with providers, to connect with support for any of our patients. And warm handoff time totals about 2 hours per day, and that varies if it's in 3 or 4 hour chunks, if they're in pediatrics or in family practice, so that they are available for their teams. They are able to connect and do all the things that they need to in order to make treatment successful. We have a treatment-based registry that monitors all the clinical measures. So just like Ashley was saying, we are also on Epic and have that as something that are managing our patient engagement, what is our treatment efficacy like, and identifies any risks. And that is spread across so that it's not just available for our IMHTs, our therapists. It's also available for our PCPs, psychiatric consultants, because everyone is employed under a multi-care, so everyone has access to the same information. Fully financially sustainable, we do bill a combination of CPT codes for therapy and collaborative care minutes. And we do weekly consultations with a psychiatric provider. And it is 2 hours of a psychiatrist or psychiatric ARNP per week. And each psychiatric provider is dedicated to one clinic. So they have consistency of who is providing that recommendation, or if they need to go back and consult, they can have the same person again. And a unified clinic team where they're attending everyone's meetings. They are part of the primary care team. They're working on goals. So really being able to collaborate and work with the team, saying, okay, this patient is getting ready to graduate, or if they're also, not going to be graduating and needing to go to a higher level of care. I'll talk about that in a sec. Next slide, please. So what is our structure? Because I think this is another important piece. So our leadership structure, so I am the manager and I oversee both sides of the state, and I'm a 1.0 FTE. Also, our supervisors are part-time supervisors, but primary integrated clinicians. And that is so that they're able to help the team be able to do everything and any epic changes that come up that they're able to demonstrate, all of that. So we have also team leads. So we have 7.0 FTEs of family practice integrated therapists and 5 in pediatrics, 7 psychiatric ARNPs, 4 MD psychiatrists. And we are currently in 10 family practice clinics and 5 pediatric clinics. And the family practice clinics does include one of our women's, which is also a women's family practice clinic, but we are expanding into women's services separately. Next slide, please. So health equity. So we're really looking at how do we come from a behavioral health lens, but really fit in with a medical model, use our technology that we have to be able to communicate with our patients. So we're integrated into the full medical system. So we're using the medical forms, medical information, and distribution of communication. So like Ashley said, we use MyChart a lot. We send patients messages. They are able to send it back. They're able to fill out PHQ and GADS and other forms ahead of visits. The PCP is able to see them, the consulting psychiatrist. So everyone has the same access. We're also payer agnostic. That was really important to me and our leaders, that we're able to take commercial, Medicaid, and Medicare. We have some clinics that are almost 50% commercial and Medicaid. We are all master's level providers, associate and independently licensed. I really look at the clinic. I'm looking at what is the proportion of Medicaid and Medicare when I am deciding what type of a provider to hire. If I have a clinic that has a high Medicare rate, like I have one clinic that is 55%, I'm going to make sure that it's a fully independent licensed provider, such as an LICSW, LMHC, or LMFT, to be in that clinic so that we're able to be payer agnostic. We're reviewing clinical data for that decision making. So I'm really looking at what is the amount of patients that are in that clinic? What are the most common diagnosis? What is other challenges that are coming into play when setting up kind of the program? And all of our clinicians are full-time in person and in telehealth appointments. Next slide. So how do we do this relapse prevention? So I was kind of trying to set up the stage for you of what our program looks like. So just like Anna said, we start discussing relapse prevention at the initial assessment or their evaluation, because our goal is that we have given you the tools and skills that you need so that you are no longer needing to see us. When does the actual treatment relapse prevention plan starts? And that is around visit 10 for us. And the requirement is that all of our clinicians start having this conversation at least at visit 10. And what does this mean? So we're talking about the current progress of where did the patient come in? Where are they at now? What has gotten better? What has not gotten better? This is also the time where we start having a conversation. Do they graduate or do they need to transfer to a higher level of care? So in Washington State, we are the largest behavioral health care providers, and therefore we do have luxuries of having all sorts of levels of care from inpatient to residential. So we're really looking at this model. Okay, maybe we thought that this would be a good fit, but it turns out there's other things that have been uncovered. So we're going to need to transition you to a higher level. And how does that look like? We're going over all of their skills and implementation. So ongoing, so these are the things that you are doing on a day-to-day basis. And these are, things that you're going to be able to do coping when stressful situations arise, when you have triggers, when you're starting to see warning signs. What does all that look like? We talk about the new current baseline. So oftentimes patients think of their baseline of prior to coming and engaging in care with us. But we want to say, okay, after 10 visits, this is where you're at. This is more or less your new baseline. Where are you now and how is this different? So then we're able to say, okay, from this standpoint, what are your warning signs? Is it that you are not getting up for work on time? Is it that you're not answering your phone? Is it that you are no longer going to the gym or meeting up with your friends? Whatever that may be, and writing all this out for them. And again, we also have a dot phrase that we use in Epic so that patients are able to see that, because everything is accessible through MyChart for us. The patients can have this as a separate document, but also can see this in their visit notes. We look at medication. How are their medications going? Are they stable? Are they, have they been on it for a while? Are they needing an increase or a decreased dose? Are they having side effects? This is part of our relapse prevention plan to ensure that you are not needing another psychiatric consultation, or hey, we are needing to make sure that you do get a psychiatric consultation so that if this is going to be kind of the long-term treatment, what does this look like? And making sure that they have also had that plan and being documented of if this needs to change, here is what it needs to be. With all of our psych providers being in our system, it's very easy for us to have good communication and say, okay, this is what my first line, second line, third line of recommendations would be, or if these things start, reconsider. So there's great communication between our primary care providers and our psychiatric providers, and that is part of the relapse prevention plan. So if something comes up, the primary care provider knows exactly what's happening. We're looking at the visit schedule. So this is really where the goal is. We're starting to see patients, if we're not already, every other week. And part of the relapse prevention planning, we're trying to get to see them about once a month, because we're really trying to say, okay, how are you doing on your own? How are you using your skills and your tools so that we can make sure that you are no longer needing that? And then also who to contact. So they know they can always go to their PCP. They know they can always my chart message. They know they can always put in a referral, or who else in the community is going to be aware of their relapse prevention plan, and who else is going to be, maybe saying, hey, I know you used to be much more engaged when we were going out, but now you're declining all my calls. So someone else who's going to kind of give them that nudge, nudge, hey, I think maybe you want to contact your providers again. Next slide. And that's really kind of the biggest piece of having that full-on conversation and putting that not only in our notes, but in a separate document so the patient can access that. And then we will print and give that to them at their last visit, and then also send it to them via my chart or mail it to their home address, whatever they prefer. And then also share it, make sure that their PCP has had that as well. And that's it.
Thank you so much. Many thanks to our presenters. It's interesting to see the commonalities in your RPP, in your relapse prevention plans of like warning signs, what's the medication you on, but then also the variation in where you're distributing that, how you're distributing it, what you're calling certain parts of your relapse prevention plan, which I think just kind of spins back to Anna's point around making it your own for your population that you're with. And so I think setting that stage of what your agencies look like and your organizations, like the complexity of them, also plays a part into what you have in your RPP, what you have for your patients in terms of future ongoing, if they need to come back, if they need higher level of care, some of those things. So it's really valuable, I think, to hear those things. And thank you all for being willing to share your learning and your lived experience with us all on the call. So now it's time for questions, and Sarah will read from questions that were submitted. You all can continue to send those in if you have additional questions for Tatiana, for Ashley, for Anna. You can send those in at any time, and I will turn it over to Sarah.
Great, thanks, Monica. Great, thanks, panel. That was a great presentation. We have, Tatiana, there are a couple different more programmatic questions around how your program is structured. So first, what do you mean by no 3 back-to-back visits? That was the first question.
Yeah, so no more than 3 back-to-back visits. So, and that is the way we build our schedules. So it's 3 visits and then a warm handoff. And the warm handoff is equivalent to a visit. And that is the opportunity for the IMHT to talk to the PCP, to be making any outgoing calls, to any of those connections. What we don't want is patients, because we know that the demand is high, that patients are just scheduled back to back to back to back to back, and then their entire day, and they're not available to work with our team. So we have that built into their schedule permanently so that they are engaged and active in their team and able to discuss things like the program or their relapse prevention plan, especially.
Another kind of program or broad program question is, how do you have patients sign that they're part of collaborative care so we can build?
For us, we have a couple of different things. One, we have to make sure that the consent is done by the provider from the visit. And two, we have paperwork that they are signing saying, I agree that I'm part of collaborative care, that this is being billed to the services, and that is reviewed and explained to them at their first assessment or intake.
So we do the same in terms of documenting consent in the primary care visit, because the treatment is all ties back to the primary care provider and they need to document that. We have a smart phrase that our providers can use, or they can free type, which is fine. And then in terms of for our patients, we do have that welcome letter that we sent out, and we're working on them being able to electronically sign. But for now, when a patient is a patient of the primary care practice, there's language in like that primary care acknowledgement that they're going to be receiving services from a multidisciplinary team. That's also in the standard primary care paperwork when they first become a patient or if they sign on with us.
Thank you. Again, like another kind of more program question, maybe both of you can answer. What's the caseload expectation for a full-time collaborative care clinician? And then the second part of this is how many patients are reviewed in the 2 hours a week of psychiatry time?
I can start with that one. So, for our family practice, the expectation is 65 to 75 patients for the caseload. For our pediatrics, it's 55 to 65. And for our psychiatric consultation, it is 8 patients for the 2 hours of a minimum for our family practice and a minimum of 6 for our pediatrics, because we know that pediatrics are a little bit more complex and have a couple of different things. But again, it varies by the complexity of the patient.
And for us, so our caseload target per BHCM is 75. And so with our, give or take, it's always a rolling open door. And with our psychiatrists, we have dedicated 6 hours a week with them. However, we have up to 24.
How about for both of you, what's the average time frame a patient is in the relapse prevention phase, maintenance phase, for example, after achieving goals, 50% reduction in screen scores, example?
That's a good question. So anecdotally, I would say for us, what we've experienced is typically a year, over a year for when they reach back out to us. Sometimes it can be 6 months, depending on unforeseen circumstances and life stressors for the patient. But what we've seen is a good chunk of time.
So for
sure.
our actual relapse prevention phase, it's usually about 3 months. We say usually it's about 3 to 4 months of where they're doing more of the actual treatment, and then we're monitoring for kind of about 3 months in that relapse prevention. So they're usually being seen every other week or monthly, depending on how things are going before they're graduating.
How about for pediatrics? Any pediatric specific tools for RPPs that have worked well?
I can start. We like to use the PSC 17. That is pretty standard in a lot of pediatric offices, and it covers a broad spectrum. For our anxiety kiddos, we like to use Scared as well, and those are also part of our registry, so we're able to track them, but give that as an option to families and parents as well.
We don't have pediatrics, and I'm realizing I answered the prior question wrong. So for us, in terms of the monitoring, when they reach like that relapse prevention stage, is agreed. It's usually like 3 months, and we're checking with them like every other week. And sometimes we'll drop down to a month, depending. And I see the caseload is at 65, 75 patients per year or per 6 months. That's like the standard that's the goal on a monthly basis.
And I'll just add another tool that we see pediatric practices use often is the short mood and feeling questionnaire to monitor for depressive symptoms. as well. And then if you having somebody who's experiencing trauma, we might incorporate other tools too, like the CATs. So it can vary on kind of what you're treating that patient for and then monitoring over time.
I think I want to add on too, since we're doing the add-on, we're being the add-on crew today. So for the I don't think everyone could necessarily see the question. So there was a question in the box about the caseload. And is that 65 to 70 patients per year or per every 6 months? And so I think that's what Ashley was commenting on, that it's like it's rolling. And so it's not per year, and you can't even say it's per 6 months because it's rolling an active caseload from that standpoint. Is that the same for you as well at Multicare, Tatiana?
Yes, that is the same. So it's very much about having an active patient panel is what we like to call it, of that amount. Um, Keeping it kind of within that structure of what works, just based on, always being able to take new patients as patients are graduating.
How about, so after the relapse prevention plan is created and clinical goals have been met, what's the maximum amount of time you should work with a client until final discharge? I guess from each of you kind of programmatically, for Anna Hink, if you have any thoughts too as a clinical trainer.
Yeah, so for us, we usually keep patients on a month, because if you keep them on longer, they might drop out because they're feeling real good and aren't gonna continue to engage. It depends.
So for us is we don't keep people on if kind of their relapse prevention plan is complete. So, it's up to about 3 months that they're on the relapse prevention plan and they're checking in and they're seeing. Um, but after, kind of all their goals are met or they're at the 16 session mark, that is really what is prompting kind of either the graduation or transfer, depending on each client's needs.
Yeah, and I would agree. I think it does depend on different programs and the criteria they're sort of guiding their program on. I would be, maybe more cautious of having a patient complete care if I know there's contextual things going on in their life where they may have frequent crises coming up. That patient I might say, let's kind of just monitor for a little bit longer versus a patient who seems to be doing well for a sustained period of time and hasn't historically had a lot of contextual issue sort of interfering with their improvement. So it can be really based on the client too and their particular needs.
You sort of just answered this question, but I guess any other thoughts about an extended RPP? Does that prompt patients to drop out of programs?
I'll start. We haven't had that piece just due to the fact that usually our therapists have such a great rapport with those patients. And so they're wanting to, finish up and work through what they're working through. Because again, it's not just when the relapse prevention plan, they're just not checking kind of like, oh, 2-second check-in. So we don't see that patients drop off.
And I would say with anything, you just might have patients that want to stay on longer because they really enjoy their time with you. And there's this trust and rapport that's there. So it is about really focusing on celebrating their success and sort of really making sure they feel empowered and that they can use those skills on their own. So they do have as much confidence as they can have in sort of ending care in a way that feels good for them.
Yeah, and our psychiatrist, to piggyback on that, so our psychiatrist is more apt to keep patients on a month just to make sure. And we do have patients, exactly, Anna, ask, can I just stay on one more month? One more month? So, but kudos to them for asking for what they feel like they need.
The importance of advocating for
That's right.
yourself. Absolutely. No one can get upset at that at all. So I want to thank you all for answering the Q&A. I know there were a couple of other questions that were there in the Q&A. And for those of you who may have jumped on a little bit late, because I know we are all trying to get back in the swing of things for the week, I'm going to ask Christy to please drop in the chat box again for everyone the links to our implementation office hours. We have a implementation office hours that happens every month. We have a finance office hours that happens every month. And we also now have a behavioral health care manager learning community that happens every month. So I'm going to ask Christy to please drop those links in the chat for you. Please come to those, join those, ask your questions and bring your questions there that are relevant and apply depending on which office hour you are coming to. And so here also are some additional resources for those that are interested. There's some information on relapse prevention planning. There's information there in English and in Spanish, as well as an article around the role of RPP for depression in collaborative care. So we encourage you to pull those resources. You will get a copy of this PowerPoint presentation for you to have, as well as the recording. But if you want those resources quick, there they go. So feel free to pull those and use them. And here are the upcoming dates for our quarterly webinar series that we do. So we do our quarterly webinar series every 3 months, same time, 10 a.m. Pacific time, and different topics related to collaborative care. We are working on locking in which topic goes with which date, but know that we have some good things coming up this year around metrics, looking at data metrics. Always want to talk more about health equity. Thank you, Tatiana, Ashley, and Anna for adding those components into your presentation today. And so just lots of good things coming forward from that standpoint. We absolutely want your feedback. Christy did put a link in the survey for a survey in the chat box. So please click that link, complete the survey if you have additional ideas of what you want to hear about regarding collaborative care. We take the suggestions from our colleagues and peers in the field. That's how we come up with the topics. And we are doing some new things for 2025. For your own self-care, we're giving you time to transition to your next meeting, patient, whatever it might be. What we know is oftentimes we are back to back to back with meetings or patients or just the things in the way that we schedule ourselves. And it's important that you take care of yourself. You're a vital part of that healthcare team, which means you do need to take care of yourself. So we are giving you transition time to go to the bathroom, grab water, grab a snack. What do you need to do for you in the next couple of minutes before your next task, meeting, client? Thank you all for coming today to the quarterly webinar. We thank you for attending, and we will talk with you soon.